So I'll say on a personal level, I also am someone that's lived through transition of care in a very simple way. I have a common AV canal when I was little, and so I was followed by a pediatric cardiologist. And when I transitioned to an adult cardiologist, it was not good because apparently you don't read echoes quite the same. And so I'm now followed at a adult congenital heart defect center. And I will never, I don't care if I have to drive hours, I'll never go back to a traditional adult cardiologist. And that's only one specialty. And I think the big thing with leukodystrophy is that it's not just one specialty. So I only needed a cardiologist, but a lot of our patients need endocrine and urology and all sorts of people. And I had some medical training, and I still was what you would call a transition failure, meaning I like disappeared for about 7 years. So I like to tell some of the adults when I'm talking to them about this, because I think sometimes it can come across as like you're not compliant or you're not doing what you're supposed to do. And it's just life happens. And so I like to tell people that just for these teenagers into young adults, because it is a no judgment, because I was a definite dropout failure. And I unfortunately don't have any financial disclosures. Okay, and so just briefly to give some history. So there's been tons of work in this, and God Transitions and Child Neurology have great programs that kind of spell out exactly what to do. And they have this kind of model that's more for people like me, right? Where you only have one specialist. But like I said, I think in leukodystrophy, this is much more complicated. And I think it's also nice to point out that regardless of if you're at a Mass General where you can stay within the hospital, or if you're at a children's hospital, there still needs to be a transition, even if you're staying with the same provider. Because one of the big problems is that it's no longer the parent's decision how to guide care. It becomes the adults. And so even if you're going to see the patient forever and ever, there still needs to be this transition, because who's the center and who's the leader of those decisions has to change. And so I think but this is basically saying, why is it important? And I think there were words that but it's this idea of, so I liked this idea of a fish, because I also have experience with killing fish, unfortunately. And this idea that you can't just take the fish home from the store and pluck it into the new tank, right? You can't just, because they die. And so it needs to be multiple steps, right? You have to do all these different things to get the fish used to its new environment so that it can survive. And that's really the process with transition to care. It's this very long process that now that I have a 12-year-old is kind of crazy that 12 is when it's supposed to start. But I know at Mass General, 13 is when you have control over some of your medical records. And so you have to start a lot earlier. And one thing I did over the course of this year was reach out to some of the men with ALD and ask them, why do you not go? And it was interesting because it was similar to some of the reasons I didn't go. That I think as pediatric people, we do a good job of teaching these kids that you can do anything, right? That's the beauty of all these amazing treatments that you guys are developing, is that these kids should live and be able to thrive. The problem is that when you hear over and over, you're great, you're fine, you could do anything, sometimes you miss the part, as long as you take care of yourself. And so in ALD, a lot of men don't get their MRI, but they're like, well, it's been normal. And that's kind of the same reason I didn't go. It's like always my echo's that my echo, right? So why keep going? So to give you a little idea of why this is so important, I pulled some of our numbers, and I looked it up last night, and it's about 44%. It's not about, it's 44% in the last half of the year of our patients are adults. For ALD, it's about a third. But I think that that third is a little deceiving because that includes a lot of women. So that means tons of men are being lost. And in our center, as we were talking last night about, I definitely have some of that, like, I don't want to let them go because they're clearly my child. We are lucky because we have other neurologists. So we have movement specialists, we have ataxia specialists, we have sleep disorder specialists that are in the adult world. And so we keep them in the PD leukodystrophy clinic, but we're really kind of advisors and we're sending them to these other subspecialists. But many centers wouldn't have, in Boston, we've got a lot of neurologists. Like a lot of people have 2 or 3 neurologists. That's not the norm. And so I had pulled this a year ago to try to kind of convince Anna that they need to also fund for these adult LCNs. And so this is our experience. And I think one thing that's unique is that a lot of these kids that fall, or not kids, they're adults, but they're like in the 20 to 30 range. They're not all older adults. And so we've seen in the previous 6 years, 230 adults from all over. And I think it's largely because there's not many places for them to go. And I also tried to think of some of the places that they kind of get lost. And I think we all know that some end up lost in neurology groups, and especially frontal temporal dementia is one that is drives me crazy because of what I call the leukodystrophy associated with CSF1R, because I can't remember the actual name, but psychiatry is also a huge one. And we've had patients that were diagnosed because they died in jail. We've had patients that are just locked on psych wards. And then even once they have some movement things, people think, oh, well, it's from the drugs. It's because they're on all of these antipsychotics. And so they have some Parkinsonian features, but that's what it is. And I think the other reason these adult centers are so important, and I think just funding maybe care coordinators for some of them, is that kids come usually, not always, but usually with a support system. A lot of these adults, if you start having psychiatric problems because the front of your brain or your cerebellum isn't working, people leave, your support system falls away. It's a lot easier to isolate yourself when you're 30 or 40 than when you're 6, I think. So this is one of the men that we cared for. And his brother is someone that I think is also, I volunteered to be on these committees, although he doesn't necessarily know that. But he passed away from cerebral disease, and he knew he had ALD, but he didn't come to us until he had really advanced disease. But I think some of the things that make this population so much harder than someone like me with a congenital heart defect, right, is that it's complex. You can have more intellectual challenges, and that it's genetic. So it's not just him, right? It's him and his mom and his brothers. And so there's a lot of people to try to take care of. Whereas for some autosomal recessive disorders, you're more going to have just one. But I still think after listening to yesterday that some of this might also be true for these Krabbe patients that you're predicting for the later. Okay, so ALD is an example. And so this is data that I pulled at the beginning of the year for Florian and was probably the most sobering data I've ever seen, and kept me up at night because we have to do better. So I wanted to show that there's a change in the focus of care for many of the leukodystrophies. And I listed ALD as an example, but I think many of the other ones like MLD also have this peripheral disease component that becomes more pronounced as you get older, right? And so you can see here, basically half of the boys we see in our clinic that are children with ALD really have no neurologic symptoms, right? If they're adrenal insufficiency only, they come in, we check them out, and we say, you look great. And they don't have many neurologic needs. On the other hand, the adults we see, only 8% of them have no symptoms. And many of those are the women. So they need neurologists and they need physical rehab doctors, really, and they're not there. And then I wanted to also point out that I think one major risk factor for ALD is that many of them are developing symptoms right at the time when you're transitioning. So for our hospital, it's 22. So when you're 22, you go to the adult floor. I can't see you unless you have a leukodystrophy. I have a right out, but and that's like right when they're starting to have symptoms. And a lot of these symptoms are not pleasant. They're, erectile function things and they're bowel and bladder things. And erectile function, especially, at least me as a pediatric person, talking to like a 19-year-old boy about erectile function, not like my strength. So I think it is another problem. And so this is the data I was talking about. So this is the survival rate for the patients with cerebral ALD in our center. It's not good. And for childhood disease, it looks nothing like this. But most of these men are living a year and a half. And many of them don't have that high of a LES score. They might have a 6 or 7, but their brain can't handle that level of disease. And so the one that I was ready to just hang up my hat and say, this is a failure, is this slide. Half of those men knew they had ALD. So that means newborn screening wouldn't have saved them because they knew from childhood and they didn't come because they didn't have any place to go. And so it's not a ton of men, it's 12 men. But to me, that is personal. I mean, I understand it's not a personal failure, but that is unacceptable, right? We can't have people that we should have been able to treat, but that we didn't have a place for them to go. And so this is how we're doing. So I don't know how other centers are doing. And so, but I'll say that I know that our center is not doing good enough in this. And so the recommendation is every 1 to 2 years that you should be having an MRI. And that blue part is how many of the men that we're seeing that are coming to us are actually having that MRI. So I don't think that we're the exception. I think that these men aren't getting them. And when we look at some of the national insurance data, utilization of radiology services for AMN, it's bad. Their psychiatric use is much higher. And this was, again, so Ken is the person that I was telling you about who I have volunteered to be a leader of this, although he's not even in the room, but that's okay. And he has reached out to the AMN men's group and gotten some feedback from us. And I do think that Dr. Fatimi is going to speak, and some of these trials are also going to be important because it gives hope. A lot of the men, their thought was basically, there's nothing you're going to be able to do anyway. Some of them had very good faith in their wives were going to detect cerebral ALD before an MRI did, which is nice, but not true. And some of them were even being seen by providers that were telling them they didn't need it. And so going back to, I think what Anna had said, there are models. So one of our, I don't know what you call it, like students or summer people put together this list. So this is, so God Transitions has tons of these. And we did this. And I was amazed how many of the boys didn't really know what AMN was. And then also some of the parents' reactions to us saying AMN was like, we had said like a curse word or something, like, we don't talk about that. But AMN is, we see men with AMN in their 20s, their early 20s. It's, imagine if I had brought up the erectile function. It would have really. And so this is what I think would be our, dream, where we would have these leukodystrophy centers that have all of these different parts. And I think there are some centers. There's a group in Florida, the Mayo, I think, has one. They're just not always included in this. They're more these single physicians that are working. And so I think on the other hand, instead of just saying my view that, you know, there's clearly opportunity for improvement. And I think just talking about it and making sure that we're educating kids and that we're not afraid to talk about these things is very important. And then I think increasing trials, because it is really hard to want to go if there's nothing that can be done. And then this is my thank you slide. So we have amazing research coordinators, including Camille, who has abandoned us for Rochester and will be an outstanding physician. And then Florian, who's very sorry you couldn't be here, but you know, has been my mentor. And then we're so lucky we have Dr. Nagy that's joined us. And like Anna said, we have Yetta, who is coming up and is going to be fabulous and is going to focus on CSF1R. And so I think I have been very blessed to be surrounded by amazing professionals.